Thank you for joining us for this installment of the Root Cause Coalition's How-To webinar series. My name is Rachel Carlson, and I am the membership coordinator here at the Root Cause Coalition. Before we get started, I want to go over a few logistical items for the webinar. Attendees will be in listen-only mode for the duration of this webinar. The webinar is being recorded and will be available to view at rootcausecoalition.org later this week. Our panelists will be taking audience questions at the end of the presentation. If you have a question during the presentation for our panelists, please type your question into the question pane located at the right side of your screen. If you have any technical issues while you are on the webinar, you can also type them into the question pane and I will respond to you and help you out. We are so excited to have our esteemed panelists join us to share their expertise on how to leverage community investment to achieve health equity. At this time, I would like to pass it off to Robin Hackey and Aaliyah Gaskins from the Center for Community Investment. Robin and Aaliyah, take it away.
Thank you very much. It's a pleasure to be here with you, and welcome everybody. We are the Center for Community Investment, a 2-year-old initiative, and our purpose in life is to help people think about how they can use investment resources, and we'll define what we mean by that in a moment, to really change the equity results that we're seeing in our communities at a scale that is not possible with grants alone. And so when we think about directing investment resources to the priorities that communities set, whether those are affordable housing or safe places to play or other forms of opportunities that really ought to be available to everyone, what we see is that we have some pretty steep hills to climb in terms of getting money into disinvested communities, and that's what we're trying to achieve. Next slide, please. We can keep going. So it will come as no shock to any of you that as we've gotten more sophisticated about understanding the social determinants of health, we know that place really matters for health equity. And if we're going to expect people to be able to live their healthiest and most fulfilled lives, we have to have a whole lot more of the places on the right and a whole lot fewer of the places on the left. So how do we do that? Next slide. Let's start from some kind of basic terms. When we talk about investment, we are talking about investment as opposed to spending. And spending is what you do when you buy something without the expectation that you're going to get your money back. So you buy an ice cream cone, you expect to get value from the ice cream, but you don't expect the ice cream to pay you back. When we're talking about investment, we're talking about investment in the expectation of some form of monetary return. So you may or may not get a lot more than what you put out in the first place. You may get all of your principal back. You may get some interest or multiple times the money you put in, but you will have some kind of monetary return. And when we talk about investment, that distinguishes what we mean from what we refer to as a more poetic use of the term investment, like we're investing in the future of our children. So our children don't pay us back usually. I mean, they become productive members of society, best case, and so there is a return on that investment, but it's not a monetary return to us. So if you think about that as opposed to, let's say, student loans, where actually somebody is paying back the money, that's the distinction that we're making here. So the student loan would be investment. Investing in the future of our children is spending we do for love. Next slide. So when we're talking about community investment, what we're talking about is a kind of financial work that regular capitalism or regular procedures in our society are not taking care of in the way that we aspire to. So when we think about how money gets invested in general in the stock market or in other forms of market-based activity, the money goes to the easy things. It goes to the things that are profitable, that are repeatable, and that don't require a great deal of tailored and specialized attention to make happen. But what we are seeing in the communities where health equity is an issue is that there are decades of intentional disinvestment that need to be overcome here. And so there's nothing particularly easy about that kind of investment. When we're talking about community investment to overcome the structural racism and redlining and other forms of discrimination that have been in these communities for years, what we're talking about is really making an intentional effort to use money in a different way. And not surprisingly, as we say here, the well-being of the communities in our country is tied to how we invest in them today and how we have invested in them in the past. And so when we work with community development financial institutions or development agencies or others that are looking at community investment as their mission, they specialize in doing this kind of what we refer to as uphill investment, right? Money flows downhill, and they're going to make it flow uphill to places that it wouldn't go all by itself. Next, please. So why should we do the engineering that's required to make the money go uphill? Well, what we say, to put it very simply, is man does not live by grants alone. So grants are scarce resources. There are some things that only grants can do, and we want to leave the grant money to do those things that it alone can accomplish. There are other things that can be done with investment dollars. There are lots more investment dollars in this country than there are grant dollars. And so when we can use investment to do the things that we're trying to accomplish, it's a lot better for us to leave the grant money for the other things. So what you see in this table is kind of a division of how we think about this. You know, you can achieve a number of different objectives that sound quite similar, but some of the approaches are really going to require spending, and others can be accomplished with investment. So if you think about access to food, for example, a food bank would need to be something that you do with spending, because there's not a model by which you get paid back. A grocery store is, if it's a going concern, something that could assume a certain degree of debt and pay you back. Now, the building for the food bank, arguably also an investment, because you could pay a mortgage. But most of the things on the left are primarily grant funded, and on the right, primarily investment funded. Next slide, please. So what are the tools that we use to make money flow uphill? And there are some specialized things that you may be familiar with. Next, please. The key trick in making money flow uphill is to recognize that not all investors are the same. And the community investment institutions, CDFIs and others, work by recognizing that the investors who are more like the ones on the left, who have grant dollars or forgivable loans at their disposal, are what we would call impact-first investors. So they may care about getting some money back, or, you know, as they move to the right, getting more money back, but primarily what they're after is some kind of social return. The investors on the right, whether they're banks or insurance companies or other asset holders who really do expect a monetary financial return, may be also interested in getting impact, but the question is, what mix are they looking for? And so when you recognize that you can put together different types of money, different types of investors in the same transaction, that's where the magic can start to happen. Next slide. So the way that you get the magic to happen by blending these different types of investors is what we call a capital stack. So if you think about it in terms of dessert, which tends to be my favorite way to think about it, the people who have grant money are the sheet cake. And if you have $1 of grant money and you care about, let's say, making sure people have affordable homes, you could purchase land to build affordable housing with $1, and you'd get $1 worth of housing, which may be an excellent thing to do, but it doesn't involve leverage. When we think of grants as being part of the capital stack, the idea is that we're going to use that $1 of grant money to unlock investment from the investors that were over there on the right-hand side of the spectrum who were financed first. And they would allow us to build the layer cake. by coming in on top of the grant money and being convinced that they will get the return and not bear more risk than they're willing to tolerate, because you, as the grant person, have put in either a loss reserve or more generally what we refer to as a credit enhancement. So if you go at the bottom of this capital stack, at the bottom of the layer cake, and then you allow people who are more financially minded to come in on top of you, then you could use your, let's say here in this example, $2 million of grant money to unlock another $8 million of investment from people who are more risk averse. So your $2 million bought $10 million rather than just the 2. So the upshot of this is nobody chooses sheet cake when they have layer cake on offer. Next slide, please. So when we talk about credit enhancement, what we're really talking about is any way that you can reduce the risk to the investors who don't want it, the ones who are there on the right-hand side, without which they will not give you their money for an investment. And so loss reserves, the ability to be paid back last only if there's enough money to pay everybody, is one form of credit enhancement. A guarantee, if you think about a young person going for a mortgage and maybe their income is not sufficient, but their parent signs a guarantee and then the bank is willing to make the loan, that's a credit enhancement. A collateral, when you put up something as a way to secure the debt, also reduces the risk. So any kind of involvement by an impact-motivated investor that reduces risk can help unlock funds from others. So if we think about this in terms of hospitals, and Aaliyah will give you some examples, what we see is that hospitals have many different forms of assets that can place them along this continuum of risk and return. If they're using their community benefit dollars, those are grant dollars. If they're using their own pension funds or their endowments or their insurance reserves, they may come up higher in the capital stack, but the grant dollars from hospitals can be really key to get others in the system, like banks, engaged. Next, please. So if we think about the ways that grants can unlock investments, there are really 2 different strategies that grant makers can use. One is they can go inside the capital stack, as we were talking about a moment ago, and they can reduce risk or increase return or fill gaps that would otherwise cause a transaction not to happen. The other way that grant makers can use their grants is outside of the capital stack, but still to pave the way for investment by doing studies of market demand. So, for example, you want a grocery store. Grocery store operator wants to see that there is sufficient demand for the store to succeed. By doing that kind of demand study, you reduce the operator's risk. Similarly, if you're looking to increase the availability of affordable housing, you may want to do an inventory of vacant or underutilized properties or publicly owned properties that would allow you to secure land for those affordable housing developments. You may not actually do the development, but by just paying for the inventory, you're allowing development to proceed. You may also, if you're interested in jobs and economic development, help do a business plan for a potential business that's going to employ a lot of people in a geography that you care about. All of them are uses of grant money that make it more likely and less risky for investors to invest. So let me turn it over to Aaliyah, and she'll talk about the community investment system as we think about it.
Thanks, Robin. Next slide, please. And so what I'm going to do for the next couple of slides is talk a little bit about what we call our capital absorption framework. So now that you are grounded in some of the tools that you can use in order to leverage investment, we're going to spend time talking about how you could put those tools to work in order to get at the root causes of health inequity. Next slide. And so at the center, we believe that actors in a community, not just those who are finance professionals, but hospitals, public health professionals, local elected officials, residents, and others, need to work together in order to organize the demand for capital and to get their communities investment ready. For us, what that looks like is the performance of three functions: shared priorities, pipeline, and enabling environment. And each of these functions, and I'm going to go into a deeper dive shortly, is necessary in order to help the community get a better sense of the players who are involved in making deals happen, the resources that are available to bring those deals to fruition, and the priorities for the community that those deals and projects are meant to address. And that by working together and sort of illuminating the system and how well it's working, or the areas where it could be improved, creates an opportunity to increase the scale of investment and also the impact on things like jobs, affordable housing, transit, green space, and other things that we know are necessary for healthy and thriving communities. Next slide. So the first function in the capital absorption framework really focuses on helping communities get a shared understanding of their goals for investment. Why is this important? Because if there are resources available and there's an opportunity to direct them, we want to make sure that they're going to the places that are the community's top priority. Additionally, investors, they want to know not just where their money is going, but how their money is going to be used. I think the key thing to recognize when it comes to establishing shared priorities is that it's not enough just to say we want healthier communities. While that's important and probably the goal that many of us are working towards, the more specific we can be around kind of, what are the things that are preventing our community from being healthy in the first place? Is it a lack of jobs? If so, what kind and for who? Is it a lack or shortage of quality and safe, affordable housing? If so, then what are the types of housing we might need? Where is that housing most needed? And what's the urgency behind addressing this issue? I think the other thing I'd want to point out with shared priorities is that it's important to engage those who are most affected by the work that we hope to do. So making sure that appropriate stakeholders, not just residents, but also business owners and others who live in the community, work in the community, and are trying to help improve outcomes in the community are a part of this conversation. And also recognizing that it's not one and done, but this is an iterative process that you'll continuously want to come back to and really taking the time to reevaluate how is investment flowing to these priorities. Next slide. So another key piece of the capital absorption framework is really focused on what we call building the pipeline. The pipeline are really sort of the deals and projects that, if achieved or recognized, would help to achieve the community's priorities that were just articulated as part of the shared vision. Two reasons why working on a pipeline is important. One is that when we're working on multiple deals and projects, it allows us to move towards the community's vision much more quickly than if we're just doing one deal at a time. Many of these deals take years and years to come to fruition, lots of different stakeholders, and many types of capital. And so the more we can start teeing up the next set of deals, the more likely we are to get to the scale of transformation that I know all of us are working to see. The second reason why working on a pipeline is important is because by analyzing and understanding the different opportunities in a community, it can provide crucial data on what's working, what's not working, where are things getting stuck, who's missing, maybe different roles that other actors can play. As we mentioned before, it's not just up to the finance people, but there are roles, for example, a public health department in providing data on key health outcomes or health needs. There are roles around, providing relationships and information around who's involved in each of the different deals and who could be involved. And so the pipeline presents an opportunity to see those different ways in which other actors can engage. Next slide, please. I want to just quickly kind of talk about how the pipeline gets executed, and I do want to let folks know that on our website we have a series of resources which we call our function papers on each of the three functions that actually do a deep dive into how each of these things play out in communities and provide additional examples. But all deals start with an idea, and there has to be someone or a group of someone working to spot the opportunity. And let's say we'll use housing for the sake of this example. So there has to be actors working to say, okay, then where might housing go? What is the type of housing we need? There are others who are then play an important role in terms of framing the project and really thinking about how does this project help advance our shared priorities? What is the case that needs to be made to investors in order to get them interested and excited and eventually committed to helping move this project forward? Another key function is really packaging the deal. And so there are certain things that may be necessary in order to make this work. If we're talking about housing and we're looking at a particular opportunity, do we have control of the site? Do we have the right zoning approvals in order to move that forward? In this process, there will naturally be negotiations and trade-offs around, what's feasible, what are the priorities that are being addressed, what can we work on now versus what are the things that may need to happen later, and then the due diligence to actually bring the project to fruition. Next slide, please. The third function that is critical is really taking a look at the enabling environment. The enabling environment, for short, is just the context in which this work takes place. It's not just the policy environment, but it's also the data, the practices, the relationships for how work gets done, and really thinking about what will it take to ensure that each of these things are kind of working in tandem so that deals and projects are able to be executed on faster timelines in ways that achieve community priorities. Next slide. At the center, we believe, and I mentioned this briefly earlier, that it's not just one institution or one actor that's responsible for doing this. That when we're working as a system and bringing together, neighborhood organizations, local elected officials, agencies, and others, each of us can really take a different role in helping to identify priorities, sequence the pipeline that's necessary to achieve those priorities, and then also change the context in which these deals take place. What we're going to do for the remainder of the webinar is dive into a particular actor, so health institutions, hospitals, and health systems, and the roles that they can play in putting their resources to work to help achieve these three functions. Next slide. At the center, we are running a program now launching into its second phase called Accelerating Investments for Healthy Communities. And Accelerating Investments for Healthy Communities is really exploring this question of what are the ways in which hospitals and health systems can bring their various assets to bear, whether that's land, their investment portfolios, their staff expertise, their government relations capacity. How can they fully leverage each of these assets in order to help strengthen local community investment systems and really attract more resources to the social determinants of health? Next slide. This slide that's coming up provides just sort of a brief snapshot of the 6 institutions that we're working with through this program and the target geographies that they're looking at through our work together. So Bon Secours Mercy Health System, Boston Medical Center, Dignity Health, Kaiser Permanente, Nationwide Children's, and UPMC. Next slide. AIHC is specifically focused on affordable housing, although I think we believe that many of the lessons and the tools that we're working with hospitals and health systems and their community partners have application to other social determinants of health as well. What we are doing is exploring with them on how they can build partnerships with other stakeholders in their local ecosystem, how they can begin to identify a pipeline of affordable housing projects that, if achieved, would address the community's affordable housing priorities. We're also really focused with them on how their current enabling environment is operating and what's slowing down deals or what might help to accelerate them, and the role that health institutions might be able to play through the partnerships that they create, through the resources that they provide, or through the influence that they bring to the system in order to bring new ideas to accelerate the system. And then lastly, working to accelerate and share some progress across the field by sharing the stories for each of these institutions that, for many who are familiar with them on the phone, know that they have really been pioneers in thinking about how they step outside of the walls of their institutions and really take up their full role as actors in the community investment ecosystem. And so what we're going to do at this point, I'm going to turn it back over to Robin, is just dive a little deeper into what we're learning through this work and the different roles that these key players and anchors can play in their community. Next slide, please.
So as Aaliyah said, these are not just any 6 systems. These are, in our view, systems that have really advanced themselves into the future in a way that sheds a lot of light, we think, on the path that other hospitals may choose to follow as they get more and more engaged with community health. And we believe that given what we know now about the importance of the social determinants of health and the cost of not paying attention to them, we expect that there will be, in fact, lots of other systems that follow in the footsteps. Next slide. So the first thing that we wanted to share was that not all of the health systems that we're working with, or all the health systems in the field, are approaching upstream investment in the same way. So here what you see is kind of a spectrum of how we see the institutions arrayed. Some of them are really focused on population health, and very often the ones who have a population health focus are looking at the highest cost utilizers that are either their patients or their plan members, or sometimes both, and they tend to think about what it would take to reduce the cost of care for those high flyers. That may mean reducing unnecessary emergency room visits. It may mean housing the homeless. It may mean dealing with people who are unnecessarily likely to get into nursing homes and finding alternative places for them. So there are different kinds of housing that the people who are at the population health end of the spectrum may be focused on, but they tend to be looking at a particular group of people and solving for that group. This is the segment of the health system world that is the most focused on return on investment, the financial aspects of the work, and quantifying the savings from avoided admissions, reduced ED visits, and all those kinds of health outcomes. So in the middle, what we see is an approach that we refer to as the neighborhood is our patient. So we know from looking at hotspot data or from looking at emergency room admissions where most of the folks that we serve in a particular health institution are coming from. And so rather than a narrower focus, let's say, on behavioral health issues or on the chronically ill, we say if this neighborhood is unhealthy enough to be generating a lot of health burden, then let's treat the neighborhood as our patient. And that may mean investments not only in housing, but in safety, in parks, in schools. And we do see a number of health systems that we're working with operating in that way. At that point, it's less about a specific economic return in the short term, and it's more of a long-term investment. And we'll talk in a moment about the motivations for doing that. But we do find that beyond the economic motivation, there are a whole lot of reasons that a hospital or health system may choose to get to more of a community-level focus. And then on the right side, we see the hospitals that are really intentionally saying that our mission is not to provide health care, it's to make our community the healthiest in the nation or in the state. And they tend, when we look at their strategies, not to be only looking at a particular piece of the affordable housing spectrum, like transitional housing or supportive housing, but rather the whole mixture of affordable housing types, from family housing, senior housing, workforce housing for the lower paid people in their own workforces, or the continuum of housing as a whole. Next slide, please. Next slide, please. Oh, the suspense.
Hold on just a second, we're having a technical difficulty.
No problem. Well, while we're waiting for the slide, let me tell you a little bit about what we see in terms of the motivation for these different approaches, because right now we're not in an environment where the transition from being paid for the volume of healthcare to being paid for the value of healthcare is very far along. I think many of us see it coming, and some systems are further along towards taking capitated risk. But we don't see an environment where that is the dominant paradigm in the health industry. And yet we see systems like Dignity, like Kaiser, like the others that are in our program, making these investments anyway. And so we have been trying to understand with them what drives them to essentially do the future before the future is here for everybody else. And what we see are really 9 different factors, many of which can be present in different departments in the same institution at the same time. So the first is that we have, in some cases, senior leadership at the level of the board or the C-suite that has a strong mission orientation and believes that this is what their institution stands for. We see in that category some of the faith-based institutions who say, hey, we stand with the poor, and it's not about, the narrow investment and return on that investment. It's about our philosophy and how we choose to do business. So that's one category. But they're not the only senior leaders that we see taking this approach. We also see people who are doing what they tend to call skating where the puck is going. And if they say, hey, strategically, we understand that this is the way the world is moving, we'll have a competitive advantage if we get there first, then they're gaining experience in a mode of doing business that will serve them well as regulations change, as payers change their behavior, and so they're sort of getting ahead of the curve. Another motivation that we see for this focus on upstream investment is that there may be some kind of competitive imperative, either because they're losing staff or losing patients or losing payers by not behaving in this way, or they believe that they will be more attractive to potential patients and payers by getting ahead of this investment and being able to talk about what an enlightened institution they are. And what we've started to see in California and elsewhere is that institutions are being asked by government payers and other public-minded folks about what are they doing upstream, how are they dealing with the social determinants of health. And so being able to tell a story about the use of institutional assets in this way is really very compelling. Another thing we see, I'm on the driver's slide, you're good. Another thing that we see is sometimes there's just an irresistible ask. So let's say you are a hospital doing a campus expansion and you need some kind of zoning variance or some kind of approval from the city council or the mayor. And at the same time, the mayor has a housing plan or something else in a neighborhood that he would really like your help on. That's what we would put in the category of irresistible ask. And many of the institutions that have done upstream investment have gotten into it either because there was a determination of need, allocation where state law required them to take a certain percentage of facility cost and put it into community health, or they needed approval for a merger and acquisition plan that they had, and as a condition of doing that, there was a community benefit obligation, or the mayor asked, and it was really clear that given the campus expansion plans or other things, that it was worth doing. So we see a number of motivations that drive upstream investment. At the same time, we also see a number of inhibitors and factors that need to be overcome if an institution is going to be able to make these investments. So the first is there are institutions and departments within institutions that say, hey, this is not my job, that our mission is to deliver health care, this is mission creep, we're not interested, or if we do it and the other institution across town that we compete for patients with doesn't do it, then we will be disadvantaged. And there are institutions that are stuck in this place, and even if they have an internal champion, they may not be able to get over the hump. Another factor that we see is that there are hospitals, particularly safety net hospitals, that are under margin pressure, and they say, where are we going to get the assets to do this kind of investment? What we say to those folks in particular is you already have investments that you're making, grants that you're making, and the question is not, can you afford to do it? It's really, can you afford not to? And so if you think about, for a safety net hospital, the way that they can leverage the community benefit spending that they're already doing, this is where the sheet cake, layer cake thing can really be an important asset to understand. Because you don't necessarily have to spend more money to do this upstream stuff. You have to use the money that you're already spending in optimal ways. And the same is true with the investment of cash reserves, insurance reserves, and other assets. It's not a question necessarily of adding money, it's a question of deploying money differently. So that requires some staff capacity and the ability to bust through what may be internal silos. What we found in the program, and Aaliyah will talk some more about this, is that sometimes when we told the community benefit people that in order to play in the program, they had to bring a friend from finance, we were told, hey, you know, they're on a different floor, we don't go there. And until they had a specific reason to get into a conversation with the finance department, with the people who manage their health plans internally, these are not conversations that are happening routinely. But what we found pretty much across the board with the systems that we started to work with was that once it became clear that this was a condition of moving into the future, they were in fact able to do it and discovered a whole number of shared objectives that they were able to achieve by working together that separately had not been available to them. Next slide, please. So here are a few examples of what we're seeing from the health systems that are in our program about what difference it makes for them to work upstream. So Nationwide Children's Hospital in Columbus, Ohio is an interesting example. They, for a number of years, have worked on the south side of Columbus, primarily doing renovations for single-family homes. What they realized when they started working as part of the AIHC program was that they could use their capital, in this case, a guarantee of $1.5 million that Aaliyah will talk about more, to unlock investment from others. And they've found that that's been so successful for them that they are now moving into a second neighborhood where instead of targeting single family, they'll be working on a mix of single and multifamily housing, different demographic characteristics in the neighborhood, but a real hot spot in terms of health equity. What we found in another case with a safety net hospital, Boston Medical Center, is that they are working with a number of their institutional peers in the Boston ecosystem, where there's a whole lot of medical institutions, to think about what they might do jointly to invest upstream in affordable and supportive housing. In other places like UPMC in Pittsburgh, we're seeing them think about land that they own, that they were potentially considering disposing of, selling, as an asset that they can use to get more affordable housing built. And Kaiser, which had been thinking in some of the work that they're doing nationally about making sure that a named and numbered group of homeless people got housed, are now thinking about what can they do to catalyze robust housing systems at the system level across their market footprint. Next slide, please. So there are a number of roles that hospitals and health systems can play, and we've alluded to some of these as we've gone along. One of the roles is to really think about how do they partner with other stakeholders, whether those are public sector folks, community development financial institutions, local philanthropies, other employers, so that they can together tackle the problem, which is not at the scale that one deal alone is going to solve. So the convening role is a really important role. Sometimes the important role that the hospitals can play, and these are not mutually exclusive, is as a grant maker. So they can help organize community voice, build the capacity of community development institutions, help the community development financial institutions or affordable housing developers become more active in their geography. So they can use the grants, as we said, inside and outside the capital stack to build community capacity. Another thing they can do is take some of their investment assets and invest in CDFIs or in the projects that CDFIs bring forward. And those are investments that, when they're well structured, which there's 50 years of history in doing, can generate pretty reliable returns, 2%, 3%, 4%, which, given interest rates these days, are not all that different than other forms of debt. And they have the social return that is completely additive. We talked about land. We also mentioned that institutions can use their voice in advocacy efforts, whether it's housing policy or transportation policy, that relate to the social determinants. And these are respected voices that can make a big difference. So again, intervention that doesn't cost money, but can have a big effect on community investment. And then finally, we find that health institutions can help create demand in low-income neighborhoods by making real estate developments feasible, let's say by guaranteeing first-floor retail with a clinic or doctor's offices, or by targeting purchasing to local businesses, or to helping their employees live close to work, which both reduces commute times, increases employee satisfaction, and may help in the remediation of blighted or vacant neighborhoods. So these are some of the roles, and I'll now turn it over to Aaliyah, who will talk about what it takes.
Next slide.
And we hope you're teeing up your questions, because we're very close to the point where we would love to hear them.
Yes. Well, while we're transitioning to the next slide, I just would echo that if you take away sort of nothing else from this webinar, I think the real opportunity is that when we take an investment approach, there's an opportunity to leverage resources in ways that allow us to attract more resources, more actors, and more partners to the table in order to really increase the scale of resources that are going into a community. And so what we tend to see, and as Robin talked about, there are things that the health system itself needs to do internally in terms of really kind of identifying the respected leaders who can champion this issue with inside the system, getting buy-in from others who are critical to making those decisions, whether that's at the senior leadership level, like a CEO, but also others whose departments may not have thought they had a role to play. So in some cases, there might be a philanthropic arm, there may be folks from Treasury, others we've seen in cases even from real estate departments who can really think creatively about the assets they bring to this conversation. It takes an effort to formulate goals internally around what the health system is willing to do in terms of the role they're willing to play, but also the parameters and criteria they will use in making decisions about their investment approach. It takes partners, as I mentioned, and also capacity, really investing in how you institutionalize the work. But then at the same time, there has to be this work going on in partnership in the community to really focus on kind of creating the opportunity to identify goals and community priorities, building the pipeline, and setting the platform so that when resources are made available, there are clear and distinct ways for that money and those resources to land in order to advance those deals and projects. So next slide, please. What I want to do is just kind of quickly end with two examples of, I think, next slide the other way, of how this plays out in practice. So Robin started to talk a bit about an example from Nationwide Children's Hospital. It's actually one slide over. And Nationwide, they have been working since 2008 on an initiative that they call Healthy Neighborhoods, Healthy Families, which is really a partnership between the health institution, residents, a local community development corporation, faith-based organizations, schools, the city, and other partners to look at how they can create positive health outcomes on the south side of Columbus. You can say this slide, please. Thank you. And through this conversation and through sort of the identification of shared priorities with these different partners, one of the things that came out was a need for affordable housing. And as Robin had shown in the previous example, the sheet cake and the layer cake, they could just say, okay, well, here's a certain amount that we're going to put in, and this will be able to build X units. But by being able to structure a capital stack, what Nationwide was able to do is they provided a loan loss reserve, so they came in at the very bottom. And Rachel, can I ask you to go back one slide just so you can see the picture? Well, what they were able to do, and I know our slides will be made available later, is by coming in at the very bottom and essentially saying, we'll take the greatest risk, we'll be paid back last. It allowed those who had sort of a willingness to take less risk, or maybe more traditional investors like banks, to come in on top. And so their money was able to unlock money from others and generate a lot more money for affordable housing than they may have been able to do as one institution alone. Next slide, please. And this final example is from another institution in our program, Dignity Health, now Common Spirit. But Dignity Health has had a long-standing tradition of community investment. I think over the years they've put close to $100 million in investment in different ways, whether that's investing directly in community development financial institutions, whether that's supporting different projects from housing to community centers to health clinics. And so in our program, they started thinking about what it might look like to really support a place-based approach in San Bernardino, California, where they have 2 hospitals and is a place that is emerging from bankruptcy and really has shown a clear need for affordable housing, but also sort of other supports and resources that we know are key to healthy, thriving communities. And so in working in partnership with an organization called National Core, which is a local developer, as well as the city and other partners, they identified a gap within a project called Arrowhead Grove, which is meant to be a large-scale, 5-phase mixed-income housing project. And they said, with these partners, what can we do to help fill the gap, but also how can we identify maybe other resources in the system? And so through this partnership, after Dignity had put forth their investment of $1.2 million, I think they also worked with the partners at the table to reach out to the California Strategic Growth Council, which is a state agency in California, and were able to attract another $20 million for this project. And so the story in both of these examples is that there are different roles hospitals and health systems can play, but when they are at the table and when we think strategically about how their resources can be used, in many cases those resources can be used to attract other resources and other forms of capital to help advance larger, more transformative projects. And so with that, we are going to pause and take questions. Next slide. This slide provides a link to our website, and so you can see where you can go and access more information on any of the functions we talked about. Also, we have a paper on hospital motivations, and we have some examples on our blogs about different things that actors in our program are doing. And you can also feel free to reach out to us via email if you had additional questions that we might not be able to address today.
And we have a 6-minute video that captures all the content that we just provided in 45 minutes in 6 animated minutes of video. So check it out.
Great. Now we would like to take a minute to take any questions that anybody has. So I'll wait a minute and get some in. Please submit any questions and we will read them out to our presenters. So our first question from one of our participants asks if they're curious as to how to best measure the impact of community investments, and want to know if you, Robin and Aaliyah, have any directions or insights how to best measure the impact of any given investment on a community.
Well, I think there are individual effects, there are neighborhood effects, and there are effects on the institution itself. And so one of the tricky bits with measuring, as all data folks know, is you have to understand a lot about what you're trying to find out in order to know what to measure. If you think about remediating mold from unhealthy housing, You may be particularly interested in the effects on the asthma of the children who are living in that home, and so at that point measuring individual effects would be important. You might also, for that case, be looking at over time the cost of care of a particular patient or family. If we're thinking about an intervention that's a more neighborhood intervention, like removing blight, then the intervention is going to be harder to measure in general terms because you're intervening at the level of the neighborhood, and you may or may not be deriving financial benefit directly from that, but you may see that, more kids are able to play outside because it's safer, and that the weight of those children may go down over time. You may or may not have a way to work with the school system to see whether that's happened. So it doesn't mean that something is a bad intervention, but I think we are not yet at a point where we have the sophistication or the integration of data to allow it to measure all the things that we know are important. So being specific about what people are looking for is really a big deal.
Great, thank you so much for taking that first question. Another one of our participants asks if either of you have any ideas for local or state policy to incentivize these investment actions by healthcare institutions.
Well, one simple one is that when states are awarding Medicaid contracts, it would be very nice if they would be asking the bidders what kinds of upstream investments they have made, why they chose those particular investments, and what their plans are to do more. So the use of procurement in a way that is strategic is one thing that we think is a fine idea. Using the ability to require determination of need certificates and investments is something that Massachusetts and a couple of other states have done. And so they go beyond the national ACA requirement that hospitals that are nonprofit folks put money into community benefit, and they specifically say, hey, if you're building a new building, 5% of the cost of that new building has to go into investments that are eligible if they meet the following criteria. So that's another really good way to prompt this kind of investment.
And I would just add another thing that we're seeing too is that sometimes when you have new leadership at the local or state level, so let's say in the case of the state of California with the new governor who has made sort of housing an explicit piece of his platform, that sometimes those conversations, just the fact that they're happening and that there's a potential for new investment across the state, can also create an opening where institutions that may not have been following that issue or may not have had it on their radar, or maybe they did, but they hadn't thought about the role they could play just yet, because it has been elevated across other conversations, their government relations folks are going to start bringing that back. There may be conversations around, the type of anchor they want to be and the type of partner they want to be at the ecosystem. So really kind of other policy agendas that may not be specifically directed to the health institution can actually create a window and an opportunity for them to think about a role they could play in that space and be brought to the table in a new way.
Another one of our participants wants to know if you can talk a little bit more about building capacity of communities and hospitals to develop shared goals. Because the language of communities and hospitals can be very different, especially thinking about value-based outcomes and quality metrics. What are some approaches that you have taken to bridge the gap so that communities and hospitals can best work together?
So I'll start. I think that, so first I would say that I don't think there's a one-size-fits-all approach. I think one tool that we have found really helpful to kind of even just start is to help the health institution think through, when they say they're going to work with community or engage community, they need to be specific and clear on what that means. And so we've often used, there's a tool, we can include this in the follow-up, on the spectrum of participation. And so it kind of moves from inform to empower. So are you just letting the community know what you're doing, or are you really creating a space and a process for them to drive what you are doing? And so I think first it begins with that sort of clarity around the level at which the engagement will take place. I think in our program, the way we've tried to help build some of that bridge and the capacity is we ask each of our health systems to put together what we call kind of a home team. And the home team is meant to be made up of a range of different stakeholders who they can partner with in order to get a better sense of what the community priorities are. That might be, nonprofit organizations or CBOs that work closely with community. It might be resident groups that are in a particular neighborhood where the hospital is thinking about potentially doing an investment and wants to work with them to better understand what that investment might look like. It, in some cases, might even be agencies that I know we don't think of as community, but have done like a planning department. Maybe they've recently done a community planning process or a neighborhood plan, and so they're able to provide some of the data and studies for kind of what has emerged as community priorities through some of those formal processes. I think it's a work in process. I think we acknowledge that in some cases, health institutions have not had great relationships with community, and there's a lot of history and things that need to be acknowledged before those relationships can move forward. And so with each system, it looks a little different as to how we enter those conversations, but it begins with really getting clear on the commitment that they're willing to make and the tables that we can set, and constantly asking who's missing.
Yeah, and I would say one other thing. It's been our experience that health institutions love expertise, and a lot of the framing of the work that gets done outside the walls of the clinical environment gets framed in the same expert terms as the work that gets done inside. And I think culturally that is probably not the best way to go at it. So what I think has been more successful is when hospitals and hospital staff realize that the residents and neighbors that they're trying to talk to are actually experts in their own lived experience, and therefore have to be engaged in the language of their expertise and not expecting them to speak the hospital's language, is a really important way to think about it. And that involves maybe having a translator, and it involves listening. And for some institutions, neither of those things is all that easy, but the more successful institutions develop a mindset of operating in that way, and I think they get much better results.
Great. I think just time for one more really quick question. How, for health systems, how should health institutions assess which community organizations to partner with when there might be multiple institutions in a community? And is there sort of a rubric or a checklist that can provide guidance in identifying those partners?
Well, I think there are, as they say, horses for courses. And part of what the hospital needs to understand is what are they trying to use the partnership to achieve. So, it's been our experience that some community groups are more rooted in a particular neighborhood. Is that the neighborhood of focus? Some community groups are more representative of the demographies that are prevalent in their neighborhoods. That's usually a good sign. Some organizations have a demonstrated track record of providing services to their residents. And if you ask the residents, so what do you think of those services, you may find out, which is a good way. But what we find is that lumping everybody together in the same category, whether they're a social service agency or a community development corporation or a neighborhood serving group, is probably not the most helpful way to go at it.
Thank you so much to all of our participants for your wonderful questions. And again, a huge thank you to Robin and Aaliyah from the Center for Community Investment. This is going to conclude this how-to webinar series. This presentation has been recorded and will be posted on the Root Cause Coalition website on our webinars page by the end of this week, as will a copy of the slides and any other materials that came from this presentation. Thank you so much to all of you for attending, and have a great rest of your week.
Thank you.
Thank you.